Welcome to Emergency Education at the Bedside. Emergency Education at the Bedside, we're focusing on education of rapid responses and codes. A rapid response is when a patient is deteriorating and help is needed. You can call the team to help you. There are multiple reasons to call a rapid response. An interdisciplinary team will come to the bedside and help you. It's really important to remember that you are a member of the team. You know all about your patient and you can inform the doctors and the nurses what's going on with your patient. For codes, it's a slang term for a patient in cardiac arrest. Your patient has no pulse, they're not breathing, probably gray, white in color. And once this code is called, the rapid response team will come and others will come as well. You'll have other members from the ICU, multiple respiratory members come. You also get people like patient care services and spiritual care also. You want to start your shift strong by getting bedside report. This way you can have a visual of your patient while the night shift nurse, day shift nurse is handing the patient off to you. Getting a good patient history so you know why they're there and other comorbidities. Code status, make sure you know whether they are a DNR or they do want CPR and extreme measures. Go over all the labs, that way you have an idea of what their body's going through. Get the vital signs, whether they're you get them yourself or you get them from the aide. You want to be able to track that so you can get any signs of trouble. Their mental status, make sure they're alert and they're oriented and maybe assess that throughout the day because change in mental status can be a change in what's going on with them. Know their baselines. Some patients keep a high heart rate and stay there and the providers often know about it, so that's important for you to be aware of also. And a thorough assessment early will give you an idea of what's going on with your patient if there are changes. You'll know what's different later in the day. I'm going to start talking about rapid responses. There are multiple reasons to call in the team. There are multiple reasons to call a rapid response team, and these are most of them. A significant change to the heart rate, the blood pressure, or the respiratory rate, or if there's a threatened airway, if there's a change in mental status or level of consciousness, if there's some seizures, whether they're new or prolonged or repeated, any neurological changes, if they're in acute distress, if their oxygen saturation's decreased, even though you're giving them compensation via nasal cannula, non-rebreather, any unresolved chest pain, an acute bleed, if they've got a decreased urine output through the day, if they're not responding to the treatments for any acute problem or acute symptom. You can also call them if the patient or the family is concerned. And also if you're concerned. They're your patient. If you've been with them through the day and something is just not right, you can call a rapid response. So you decided to call the rapid. Now what do? First off, you're going to stay with your patient. You are the primary nurse and you are needed in the room. You know their history, you know what they've been doing through the day, you know why it was called. Delegate any other tasks to other nurses that come to help. This is your rapid, you need to own it. You want some vitals. You want the Dynamap and the manual cuff in there, just in case the Dynamap's not working or the provider wants a manual. You're going to assess their need for oxygen. Do you need a nasal cannula? Do you need a non-rebreather? Get the glucometer. I'm going to talk about finger sticks later, but the glucometer is important. You also want the code card. You want to hook up the monitors. The patient chart is also important. You want to make sure we know the code status. We also want a computer or wheelie to put in any provider orders and to pull up any labs or history. You also want to start the rapid response record. This is the record that is on the cart. The nursing supervisor often starts this, but this would be a good thing for you to start also. You want to be ready to explain why you call the rapid and be ready to answer questions about your patient. This may seem simple or easy, and it possibly is. These are really the important things that you need to be prepared for when the team comes. It's really important to get the glucometer. You really want to know what the patient's blood sugar is. Hypoglycemia can cause confusion, anxiety, irritability, syncope, and even unresponsiveness. Low blood sugar can mimic a stroke. You want to make sure that you know if your patient's stroking or they've just got a low blood sugar. Hyperglycemia can cause confusion, weakness, shortness of breath, abdominal pain, coma. And stress, infection, and steroids, often things we see in the hospital, can increase the blood sugar. You want to make sure you know the blood sugar so you can treat it if it needs to be treated. It's really important to know your patient's mental status. It's an important aspect of their well-being if they've been confused throughout the shift. It's important to know that if they've started out the day alert and oriented and throughout the day they're getting a little more confused, you want to make note of that. Because that can be caused by hypoxia. One of the articles that I read discussed novice nurses not knowing and realizing hypoxia before it happened. And this was an important quote I felt from the article. Changes in mental status, often occurring hours before initiation of CPR, can be an ominous sign associated with poor outcomes. Delays in response to acute changes in mental status have resulted in lower survival rates compared with any other symptom preceding code blue activation. So it can often be caught before it happens if you're paying attention to mental status and the fact that hypoxia can change that. I'm going to move on to codes. The famous code blue is where we're going to start. Your patient has no pulse and they're not breathing. Code blue. It's really important to know your patient's code status. If they're a DNR and you go in and they're unresponsive, you don't want to be starting CPR on them. That's not what they wanted. You want to let your charge nurse know in that case and call the provider. But if you do go in and you know they're a CPR, you want to try and rouse your patient, yell for help. Do not leave your patient alone. Do not leave the room. Start yelling. Check for a pulse and breathing. If nothing, start compressions. It's ideal, obviously, to have a board under your patient. That mattress can be springy. You want to get good compressions. But start nonetheless. If you don't have it, when the code cart comes, there'll be a board for you. If there's someone around and you're getting tired, make sure you swap places with them. Compressions are tiring, especially if you're going to the right depth and the right time frame. You want to follow your BLS and ACLS training. The team arrives fairly quickly when you call an ACLS, and you'll just follow what the doctor orders. I put in the algorithm for CPR for ACLS training BLS, but I didn't want to cover it too much because it's fairly standard and the doctor's going to order what the doctor's going to order. By then the team will be in there. You'll have multiple people doing compressions. A lot of people will be yelling orders. Just make sure that you're there. You can help do compressions, swap out with people. They'll get monitors hooked up. They'll be trying to get blood. They'll be trying to intubate. It will be fast paced, but a lot of people come when the ACLS is called. You won't be on your own. Something else that might come up is a code stroke. If a stroke is suspected, you want to call a rapid response. You don't want to call a code stroke. The rapid response team will come and assess, and they will call the code stroke if they feel it's necessary. You're going to continue like a rapid response, but you're also going to get the stroke lab box, which is located in the med room. If labs have been drawn recently, it is also possible to do lab add-ons, but check with your provider before you do that. Some of the signs and symptoms of stroke would be sudden numbness of the face, arms, or legs, sudden confusion, trouble speaking, trouble seeing, trouble walking, lack of coordination, and sudden onset of severe headache. It's important to remember that you called the rapid for a reason. Don't question it. You are your patient's advocate. If you feel that they need help, then call for the help. The doctors can end it early if they feel it's necessary, but you are the one that's been taking care of them all day. You know that something's changed and something might be wrong. Don't let fear of criticism get in the way of you helping your patient. Some tips to help you feel more comfortable can be familiarizing yourself with the rapid response record. Go over that record so you know what it's looking for. Also familiarize yourself with the code cart. If you're not sure how to hook up the monitors, ask your charge nurse or one of your coworkers to help you. You want to know how to do that in case no one's around when the rapid's happening. Help out your coworkers during their rapid responses. If your patients are comfortable and they don't need you, go ahead and help out and observe what's going on. If possible, shadow your facility's rapid response nurse. That's something that I did during my orientation and I did for this project, and it was extremely helpful, and it's where I got a lot of the information for this education. Brush up on your BLS or ACLS training. If it's been a while since your certification, you can watch videos to remind yourself of the process and what happens. Participate in the recertification courses. Don't just do the easy online classes, but go to the classes, do the compressions on the mannequins, and participate. If you're not ACLS certified, consider taking the course in your free time. It may be that little bit you need to help you feel more comfortable on the floor. These were the sources that I used to help research this education material. I also really want to thank Laura Harder. She allowed me to follow her during the rapid responses and the codes on a few shifts, and also to Nicole. They sat down and chatted with me, and that was really a big source of this education, and it really helped me feel more comfortable getting on the floor. I'm not as nervous, and I think that it helped a lot, and I hope it helped you too. Thank you.